Thank you for kind introduction. Good afternoon, everyone. I'm Mun Chae Choi from Department of Surgery, Armed Forces Capital Hospital. Today, I would like to share about our experience of development of transplant surgeon-innovated ex vivo machine perfusion in South Korea. This study was supported by the National Research Foundation of Korea. Due to the limited availability of donor organs, many Western countries have expanded their donor pools by incorporating organs donation after circulatory death, called DCD. Unlike donation after brain death, donation after circulatory death organs are subject to prolonged warm ischemic times. This increased the risk of ischemic reperfusion injury and early alveolar dysfunction, resulting in a lower graft survival. To mitigate these challenges, ex vivo machine perfusion has gained recognition as a promising alternative to traditional static cold storage. Ex vivo machine perfusion mitigate the ischemic reperfusion injuries through various mechanisms, primarily by maintaining a continuous supply of oxygenated blood to the liver, which support metabolic homeostasis and prevent the accumulation of anaerobic metabolite. Additionally, EVMP modulate the inflammatory response following perfusion by minimizing oxidative stress and cytokine release, thereby reducing hepatocellular injury and improving post-transplant graft function. Over the past 2 decades, research on EVMP and LT in large animal models have built a robust foundation for the clinical adoption of these technologies. However, EVMP devices remain inaccessible due to import restrictions, and current regulation limit the use of DCD donor in South Korea. So this situation drives the development of custom-made EVMP device by the transplant surgeon laboratory, setting a foundation for a future Beijing research. So the purpose of our study was to develop the transplant surgeon innovative EVMP protocol and validate its effectiveness in a porcine DCD simulated liver transplant model. 26 Yorkshire pigs were utilized as our experimental animal model. To simulate DCD, 1 hour warm ischemic time was established before liver extraction. For liver preservation, we compared 2 methods, cold storage group and ex vivo machine perfusion group. In the first protocol, cold storage group underwent 5 hours of cold storage, while machine perfusion group had 1 hour of cold storage followed by 4 hours of machine perfusion preservation. After preservation, we performed ex vivo reperfusion using porcine whole blood and observed it for 2 hours. In the second protocol, Model 2, 1 hour of cold storage time was added to both groups, and we just set up a machine perfusion. Also, observation was performed for up to 3 hours after perfusion. I'd like to briefly describe the porcine DCD model in our lab. A long midline incision with a transverse extension was performed, followed by dissection of hepatic ligaments, and the liver hilum was exposed. The hepatic artery and portal vein and common bile duct were carefully dissected, and also infrahepatic IVC was also isolated. After systemic heparination, the hepatic artery, portal vein, and infrahepatic IVC were clamped to induce the warm ischemic time prior to liver extraction. Then the whole blood samples were collected from the infrahepatic IVC and portal vein via cannulation. Subsequently, the liver was extracted, and the hepatic artery, portal vein, and common bile duct were individually cannulated for ex vivo machine perfusion. The pneumothermic machine perfusion system was composed of a reservoir, centrifugal pump, oxygenator, pulsatory pump, with a heater cooler system. With the heater cooler system set to 37 Celsius degree, the liver was placed on the custom designed reservoir. The perfusate was composed of composed of the red blood cell, which were isolated from porcine whole blood via centrifugation. After passing through the disposable centrifugal pump, the perfusator was circulated through oxygenator and heater cooler system. Portal vein flow was regulated by centrifugal pump, and hepatic artery flow was regulated by the pulsatile pump. As shown on the right, the optimization was achieved through a single adjustment process of target portal vein flow and hepatic artery pressure settings. During the 4-hour perfusion time, hemodynamic parameters were stably maintained without the technical complication. Because of a reduced target portal vein flow in mode 2, the RPM of the portal vein centrifugal pump was lower in mode 2. The perfusate pH and bicarbonate levels show improvement over perfusion time and was stably maintained. However, in first protocol model 1, there were no differences of laboratory finding between the two groups from immediately after reperfusion up to 2 hours. However, after undergoing the optimization process through portal vein flow and hepatic artery pressure adjustment, mode 2 demonstrated significantly lower levels of AST, ALT, INR, and LDH in the ex vivo machine perfusion group. Also, mode 2 demonstrated a significantly higher cumulative volume of bile production in ex vivo machine perfusion. When you look in detail about the bile analysis, there were no differences in the levels of the bile glucose, pH, and bicarbonate between the two groups. In terms of tunnel staining results in mode 1, the cold storage group showed a significantly higher tunnel positive cell ratio compared to the ex vivo machine perfusion group at the 2 hours after reperfusion. In mode 2, while no differences were observed during the preservation, but the ex vivo machine perfusion demonstrated a lower tunnel positive ratio after reperfusion. The representative tunnel stain images confirm the reduced apoptotic cell death in the ex vivo machine perfusion group. So as a conclusion of our study demonstrated the stability and reliability of the transplant surgeon-innovated novodermic ex vivo machine perfusion protocol by monitoring the hemodynamic parameters during perfusion without the technical complications, and validate the efficacy of the machine perfusion protocol in reducing ischemic perfusion injury, improving liver preservation outcomes in porcine DCD simulate LT model, and finally established a proof of concept for an experimental ex vivo machine perfusion system and showed its feasibility as a research tool for investigating organ preservation strategies and ischemic perfusion injury mechanisms. Finally, I'd like to express my sincere gratitude to Professor Zhu and everyone who helped with this study. Thank you for your attention.